Bismillah ar-Rahman ar-Rahim. I'm going to start the presentation for today. The topic today is major bleeding. This is about the guidelines and management. I've been working on these and we did present this possibly about a year and a half ago. And we have updated it and have discussed this with our hematology and our blood bank and Dr. Shalbon. So this is something which we will be distributing in the next week. And I would like all of the juniors and my colleagues to know these guidelines, that these are the accepted and guidelines as per the policy. So the source of these guidelines is the European major bleeding guidelines, which came out in 2019, and they did suggest that every hospital should have their own major bleeding guidelines and management policy. So this is in continuation of that. So I'll start with just very few quick cases, which is a 60-year-old female on aspirin catches her leg on a wheelchair and X-ray and is severe bleeding from varicose veins. Another patient who has massive upper GI bleed and severe liver disease with esophageal varices. So obviously these two cases, and then a patient on dabigatran, AFib, falls from bed. She's very tender all over the left side, elbow, chest and abdomen. She's tachycardic and hypotensive. So these three cases, and just one case we had last week where a lady presenting in ER, hypotensive, tachycardic, with PV bleed and a hemoglobin of 4. So these 4 cases present a spectrum of the problem where somebody could be very stable with a bleed to someone who is very unstable. And these guidelines do cover all of that. So what is actually major critical bleed and how we define it? So we say the loss of 50% of the blood volume in 3 hours, our blood loss of more than 150 ml per minute, our replacement of 1 blood volume, our transfusion of 10 RCCs in 24 hours. So this is kind of a vague, and it's very hard to actually say that how can I measure this 150 ml per minute and all those things. So in the next few slides, I'll give the ways how we can actually look at these things and indirectly say that this is something which is a major bleed. As I said, this is the European Guideline and Management of Major Bleeding and Coagulopathy Following Trauma, a 5th edition, Critical Care, Volume 23, 2019. This is the background source of these guidelines. The key messages from these guidelines are that traumatically injured patients should be transported quickly and treated by a specialized trauma center whenever possible. The measures to monitor and support coagulation should be initiated as early as possible and used to guide a goal-directed treatment strategy, which we will discuss. A damage control approach to surgical intervention should guide patient management. Coagulation support and thrombophilic strategies should consider trauma patients who have been pre-treated with anticoagulants or platelet inhibitors, and local adherence to a multidisciplinary evidence-based treatment protocol should serve as a basis of patient management and undergo regular quality assessment. So this is what these were the key messages, and our guidelines are based on all these. So just to remind ourselves about some physiology of the coagulation, we have pre-existing factors in a patient. It could be genetics, medical illness, medication, especially thrombotics. And then when that trauma happens, the 3 things which happen: there is inflammation, there is loss of hemostatic factors due to hemorrhage, and there is then activation of the fibrinolysis, which leads to traumatic coagulopathy, and loss of hemostatic factors due to hemorrhage leads to shock, which leads to tissue hypoxia, acidosis, and then again to traumatic coagulopathy. And inflammation itself, activation of the hemostatic and endothelium and then that leads to traumatic coagulopathy. So the end result of all these three things, inflammation, hemorrhage, and fibrinolysis, is a traumatic coagulopathy. And our aim is always to stop this from happening. This is the guideline which will be available in forms in the IPD, OPD, CCO, and everywhere, and that's how it will look like. We'll go through, I wanted to concentrate on the left side of the 6 steps, which says, what are the resuscitation steps? What is the identification? How do we do it? And rapid control of bleeding, perfusion, oxygenation, blood products and coagulopathies with the target guidelines, and the stand down debrief. So this is something, a holistic picture, which if somebody looks at it on this page only, he can do all of these things. So we'll discuss one by one, starting with resuscitation. So first of all, we need to, most likely these patients will be either in the emergency or in theater somewhere. So notify senior ED clinician, surgeon, anesthetics, consider radiology and ortho, put blood transfusion on standby, and use extension 1076 for emergencies. We must have large bore IV access, 2 into 14 gauge or 16 gauge peripheral lines. Consider IO intraosseous or central line for patients where we have difficulty in getting lines. From the ED, we will send a BBG or ABG for hemoglobin, lactate, pH, ionized calcium, full blood count, INR, APDT, and fibrinogen. We must group and cross match. In an emergency where the patient identification is unknown, one unique patient identifier, temporary ID number on electronic name pane, and a gender can be used. We need to consider arterial line and give tranexamic acid 1 gram over 10 minutes and then 1 gram over 8 hours. This is done within the first 30 to 40 minutes after arrival. Group and cross-match procedure in an emergency, as I said, we use one unique patient identifier and then the gender. As I mentioned about tranexamic acid, we all know about CRASH 1 and CRASH 2 studies, and they have clearly shown that if we give tranexamic acid in the first hour, the relative risk death from bleeding is 0.64. It increases to 0.79 if it is given after 1 hour and up to 3 hours, and then if you give it after 3 hours, the relative death risk increases to 1.44. So the recommendation is that you always try and give it within the first hour. And if you have not been able to give it, then it's better not to give it. So the second point is the identification of the source of bleeding. So we all say that on the floor and 4 more. So that's kind of a phrase we use. And obviously on the floor, we can see it, that patient is bleeding. And then we look for that. There are 4 major areas where the bleeding is. That is chest, abdomen, pelvis, and long bones. So these are the 4 more. So on the floor and 4 more. So we always need to consider, if there is nothing on the floor, we should consider chest, abdomen, pelvis, and long bones. So as we said, source of the blood loss, how do we actually look for these? In external, we can see it. For abdomen, we can do a quick fast scan and make sure there is no bleeding. For the chest, we can do CT, a chest X-ray. Similarly, Foley's catheter can tell us if there is any bleeding from hematuria, and long bones, X-rays, and all those things would tell us if there is any bleeding that we don't know. So, as I said in the start, that to say that how we actually quantify the volume of blood loss. So either you can see it on the floor, and you can say, give a guess, or you can use an ATLS classification, which is a clinical based, and studies have actually proven that they are about 80 to 90% effective in actually estimating the blood loss. Tools to help identify source of bleeding, as I said, direct visualization. You can ask paramedics who bring the patient to you that how much blood was there at this scene of injury. For the chest, you can use chest X-ray CT. If you suspect an aortic dissection or suspected aortic rupture, you can do a CT aortic angiogram. For cardiac tamponade, you can do a bedside echo. Abdomen unstable, you can do fast scan. Early and stable and clinical concern, that you can do CT abdomen. Especially for pelvis and long guns, you can use X-rays. So this is the classification used for the, this is actually a shock classification, but indirectly can also be used for the blood loss. So you can see on the top here that blood loss, if in class 1 up to 750 ml, there may not be anything in the clinical signs to tell you that this patient has any bleeding. But if it goes to class 2, which is 750 to 1.5 liters, then obviously there is blood pressure is normal, but pulse rate is high. And then going to class 3, where there's 30 to 40% of the blood volume loss, you have a decreased blood pressure and a decreased pulse pressure, with pulse rate very high, up to 140. And obviously, when there is more than 2 liters of blood loss, there is pulse is more than 140, blood pressure is decreased, pulse pressure is decreased. So these are kind of indirect but validated tools to assess the volume of the blood loss. So the third point is that rapid control of the bleeding. Remember that whatever we do, unless we turn off the tap, the flow will continue, and whatever you pour, it will go out from the other side. So although we need to resuscitate on one side, control of bleeding is very important as well. So how do we do that? Externally, we can put pressure. If we see a bleeding point, we can put pressure, elevation, arterial compression, and you can use hemostatic agents like we said about I just forgot from my name, I'll come back to it. So, and tourniquet as well. The main thing is that do not try to stitch these at that point. We have seen people who are concentrating on stitching those things. The main thing is to do pressure elevation and avoid stitching at that stage. In the chest, you put a chest drain, and then there are guidelines regarding how much volume you drain. And then if it continues, then you have to proceed to thoracotomy, and aortic stenting requires senior surgical opinion. In abdomen, if there is bleeding and the patient is unstable, then direct packing, direct control of the hemorrhage, and cross clamp of the aorta is also possible. Pelvis, we need to do the temporary closure with sheet or pelvic binder, formic pelvic ring closure, external fixators. These are the things which can be used for pelvic bleeding. And remember, pelvic bleeding is something which is very, very difficult to control. And whenever we assess a patient of polytrauma, we only look for pelvic instability once, and that's done in ER. And after that, it's not recommended that whenever someone comes, he starts to shake the pelvis. Once we have assessed that and we have put a pelvic binder, then it's not recommended to remove it unless the patient has been admitted and has been stabilized. It's very hard for a pelvic bleed to be controlled. So doing it operatively is asking for trouble. Usually it's done through interventional radiology, angiography, and embolization. For the long bones, we need to put traction splint. Example is a Thomas splint for femur, and back slabs just to stabilize and avoid any further bleeding. These are some of the X-rays. This is pelvic fracture here. This is a patient who has multiple fractures. And obviously, with this kind of injury, you should suspect that he may be bleeding the pelvis as well. This is an example of the a pelvic binder and a sheet. Usually in a hospital, you will find a pelvic binder, but if you won't, just you can even use a simple bed sheet to make it a pelvic support and pelvic binder. As I discussed about the pelvic fractures, it's very difficult, and we should always consider early intervention in pelvic fractures. I think about 6 months ago, Mustafa will know that we had a patient with pelvic bleed, and we ended up sending her for an angiography embolization in Shifa. As I mentioned, that the time is to we should not be fiddling with things that. So there is a concept of damage control surgery. It has 3 components. It's actually an abbreviated laparatomy to control bleeding, packing, and temporary closure. Say somebody is bleeding from the liver and liver is shattered. So we don't have time to actually repair the liver. So the best thing is to just pack the liver, pack it with all around it, and try and control that bleeding, and then come out and bring the patient back to the ICU, keep him there, improve his coagulation, improve give hemostatic factors, and then go back in 3 to 5 days to reassess the situation. Obviously, they need to come to ICU, and after about 4 to 5 days, once the patient is stabilized, then we look for surgical repair. This also holds true for any of the intestinal injuries where we just put clamps around it, or we do the limited resection and then just pack the areas and don't do anything further, and just come out, and even do not close the abdomen. We just sometimes keep them open. So this is indicated for patients where they are severely injured. There's ongoing hemorrhagic shock, which is not responding, and the patients have developed coagulopathy, and other factors are hypothermia, acidosis, and there may be, this can be also done in patients where you're looking at time-consuming surgeries, but the patient is unstable. So this is something which I think we have done it here a couple of times with Faisal Murad, that there were patients who were unstable. So we just went in, just did the packings, and then the patients were later taken for definitive surgical repair. So we come now to the 4th part of the guideline, which is perfusion, oxygenation, fluids, and temperature. Remember that hypothermia worsens the coagulopathy and increases bleeding. The blood pressure targets, if there is no brain injury, controlled hypotensive fluid regime. There's a concept of permissive hypotension during resuscitation. So we should aim for a systolic blood pressure of around 80 to 100 millimeter of mercury. In patients with traumatic brain injury, we need to have aim for a normal blood pressure for that age. Probably a young man, we would look for a systolic blood pressure of around 120. Resuscitation fluid, crystallite is the initial resuscitation fluid, and there are roles for possible hypertonic solutions, but there are pros and cons for that, and so we only stick to the crystallite fluids. And the guideline is that you give 1 liter of crystallite, and if patient doesn't respond, or if there is if he's a transient responder and then blood pressure drops again, this means 2 things. 1, that there's an ongoing bleeding, and the second thing is that now is the time to start for blood. So you will not give another crystallite, but you will ask for blood. But meanwhile, when the blood takes about 10-15 minutes, you can still continue with the crystallite. As I said, avoid hypothermia, so aim for normothermia and prevent heat loss. Use warm resuscitative fluids. You can use warm blankets as well, and bear huggers we have here in the hospital as well. So what are the target guidelines? This is, we need to consider individual patient circumstances in all instances, but the target guidelines are that we need to aim for a hemoglobin of 8 to 10 gram, platelets of more than 100 in traumatic brain injuries, or more than 50 if there is no brain injury. PT ratio, APTT, these are the target guidelines which I mentioned there. The fibrinogen should be more than 2 grams, temperature more than 36 degrees, pH at more than 7.35. The lactate trend should be improving. And we need to make sure that the potassium is kept under consideration, because if you give a lot of blood, the hyperkalemia can occur. So as I said, we need to call for lab and request the emergency transfusion pack. The emergency transfusion pack, you ask for pack 1, which is 2 units of O negative. This is available within 5 to 10 minutes. So you have that available straight away. The second pack has 4 red cell concentrates, which are cross-matched or type-specific or O negative, 4 units of FFP or octoplex, which is a PCC concentrate. This is mentioned in the guideline. That's what I brought it here, but I don't think this is available in Pakistan. The third thing is in that pack is the 2 grams of fibrinogen or 2 bags of cryoprecipitate. Platelets, we give 1 pool if localized bleed, 2 pools if traumatic brain injury or multiple trauma. 1 pool, that is a mega unit, is equal to 5 to 6 units. So that's what it is. That if you want to give 1 pool, that means it's about 4 to 5 units. So in roughly, we're saying that we give 1:1:1 means 1 red cell concentrate, 1 FFP, and 1 platelet. That's what we do in trauma patients, and these are the guidelines now which we should follow. I've seen here people giving 4 FFPs and 1 red cell and no platelets. So I think going forward, this is important that we stick to this regime of 1 red cell, 1 FFP, and 1 platelet in all trauma patients with multiple bleeding. The pack third is directed at our target levels, which I mentioned in the previous slide, that if we want to increase the hemoglobin, we can give only red cells and all those things. Remember, O positive red cell concentrate can be used for all men and women of more than 60 years of age. So this is important from the blood bank perspective. So the aim is that we reverse the coagulopathy. And how do we do it? We ensure sufficient platelets, fibrin, and clotting factors to form a clot. And we aim to minimize the clot breakdown. As you said, this can be achieved through those packs, pack 1, pack 2, and pack 3. How do we prevent clot breakdown? Tranexamic acid, lysine analogs, competitive inhibitor plasmine, and plasminogen. I have mentioned about tranexamic acid. This is one thing which is available with us in Pakistan here. And I have requested that in trauma patients, we should aim to give them within the first hour, 1 gram, and then 1 gram over the next 8 hours. Recombinant factor 7A has limited role in surgical bleeding, but it can be used in NOVAX, non-oral anticoagulants. So once we have done all of this, then last step is to stand down and debrief, inform the blunt transfusion of stand down, ensure that the patient has the correct name band with updated patient identifiers, because we hope that by this time we will know the patient identity. Send a new type and screen sample to the lab with the updated identifiers, and this sample will be used for future blood products. So in short, we have 6 steps to follow, and those 6 steps are resuscitation, identification of the source of bleeding, rapid control of bleeding, perfusion, oxygenation, fluids, and temperature, blood products and coagulopathies, and stand down and debrief. So I just wanted to talk about the anticoagulants for the patients who are on anticoagulants and their antidotes or reversal agents. So somebody who's on unfractioned heparin half-life is about 45 to 90 minutes. The blood test you use is APTT, and antidote is protamine 1 milligram per 100 units of heparin, max 50 milligram. May cause allergic reaction or bronchospasm. Low molecular weight heparin, the half-life is 4 hours. Blood tested anti-10A, we don't think we have it. If within 8 hours of drug, protamine 1 milligram per 100 units, followed by 0.5 milligram per 100 units, given at 5 milligram per minute. Warfarin half-life is 20 to 60 hours. Blood test to look for is INR, and you give 20 to 50 international units per kilogram of BCC complex, or if you don't have, then you can 5 milligram to 10 milligram of vitamin K, plus you can give FFP in these cases. Direct thrombin inhibitors, dabigatran and factor 10 inhibitors, rivaroxaban. We'll go to the next slide and discuss them there. Aspirin half-life is 5 to 7 days. Platelet function test, you look at the platelets. 2 pools of platelets is the antidote, and risk of surgical bleeding and increased 1.5-fold. Clopidogrel Plavix, 5 to 7 days of half-life. Platelet function test again, 2 pools of platelets is the antidote. Apaximab, 30 minutes, but platelet inhibition for 24 hours. A full blood count, you have to look at it, and if you want to reverse that, you have to give 2 pools of platelets. Thrombolytic agents, effect up to 24 hours, thrombin time, if less than 48 hours from administration, plasma of 12 ml per kilogram, tranexamic acid 1 gram, and fibrinogen. There are special circumstances we need to consider, like pregnant patients. You must displace the uterus and support woman in the left lateral position, and resuscitation of the mother takes priority. Similarly, you need to check about NTT. Consider 10 milligram IV vitamin K in patients with liver failure, and consider early present history of variceal bleeding. This is something I wanted to bring up, and I hope that our junior colleagues can look at this and have an idea about these things. This is also mentioned in the guidelines. The last thing is about how do actually you manage somebody who is on novel oral anticoagulants. There are 2 types of them according to their mechanism of action. Ones which are factor 10A inhibitors like rivaroxaban, which is Xarelto, Apaxaban, which is Eliquis, and Edoxaban, which is Lexiana. Direct thrombin inhibitors like dabigatran, Redexa, Argatroban, which is not available, I think, in Pakistan. So the algorithm for the management of patients on novel anticoagulants. Stop novel anticoagulants, factor 10A inhibitors are direct thrombin inhibitor. Stop antiplatelet agents like aspirin, clopidogrel. Stop antithrombotics like heparin, low molecular weight heparin, and do specific laboratory investigations like coagulation screen, PT, APTT, thrombin time, only for patients on direct thrombin inhibitors for bleeding, and full blood count and renal profile. If PT is normal, factor 10A inhibitor, or APTT normal on direct thrombin inhibitors, standard resuscitation and transfusion measures, meaning you can give FFP and cryoprecipitate. If PT is prolonged, or APTT and thrombin time prolonged on direct thrombin inhibitors like dabigatran, for the minor bleed, you need to do mechanical compression, elevation, give tranexamic acid. You can do local wound soaks or 5% mouthwash or 1 gram TDS. For the major bleed, tranexamic acid 1 gram TDS IV, refer to transfusion guidelines. And for life-threatening bleeding, consider factor 10A inhibitor ingestion, prothrombin, PCC concentrate or FFP. direct thrombin inhibitors like FIBA. I don't think it's available in Pakistan. But one thing I would suggest that I didn't mention it in slides because I wanted to say it, that please, please, please do call the hematologist very early in this episode. Whenever you're thinking about doing a major transfusion, you need to call the hematologist on call. You have Dr. Yasir here with us. He is an oncologist and hematologist, and you need to involve him in all of these cases. So at the end, I just want to re-emphasize that these guidelines will be available within the hospital in every department starting next week. And we would like all of our colleagues to please look at them. Thank you very much. And I'm open to any questions.
Assalamu alaikum, sir. Thank you for the nice presentation. Do we have any guidelines available on the intranet?
These will be put on our intranet as well, the hospital intranet, and they will be actually framed and sent in. They will be available in every ward.
Okay, thank you.
Assalamu alaikum, Dr. Waheed. Thank you for your presentation. Just one question, correct me if I am wrong here, that if you have renal trauma, if you give transamine, unless there's a Foley catheter, obviously Foley catheter is always placed early in any multi, obviously polytrauma or whatever, but do you still get clot retention? Do you see that at all in the ER? If you give transamine and somebody has renal trauma and they have blood in the bladder, do they go into clot retention?
Dr. Qadri, there are two things here. Number one is that these guidelines we use in patients with polytrauma. If you're talking about isolated renal trauma, we don't give transamine there. That's
right.
not. We're talking about polytrauma patient. So there we need to give transamine, number one. And isolated renal trauma, obviously we put a catheter, we sometimes get that blockage, but we have three-way catheter, we can do the washing as well. But if now this patient is becoming unstable, the next thing is either to go for an embolization or major early